exam, which is a week from today, is my understanding, for this. I'll be sure to get it there on time. Cranial nerves, what I would expect, and I just gave myself a reminder, the emphasis, as I said, the assignment goes into the weeds, goes into the forest, goes a little more detailed than you really need to clinically and blah, 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 with the intent of you can pull it back and kind of be ready a little more functionally with it. So the exam probably will emphasize a little bit more function of each cranial nerve, the assessment function-wise of each cranial nerve, and then the location in the sense of the brainstem discussion we had in module, whatever module that was. Is it module 4? 5, module 5, I was close. But it will not go into great depth about the individual cranial nerve pathways necessarily. Again, that was kind of chasing you with the assignment. You put your head into it, and as I said, coming back functionally, you should be A-okay with it. So that's clarification for cranial nerves on the final exam. The next little to-do list, the good news here, no lecture Friday. Yeah, hallelujah, don't contain yourselves. Actually, I'm kind of excited, too. Friday morning off, 8 o'clock. But we should be able to get through this acid-base lecture, which I always approach like Charlie Brown trying to kick the football each year. It's like, oh, acid-base. But anyways, no lecture Friday as far as that goes. So any questions, concerns, other than off to the races? All right, I can get rid of my to-do list. We got the record button. We'll find our PowerPoint. All right, and actually I should ask one more clarifying question. Did you do ABGs, your arterial blood gases, in ClinMed or not? Okay. I always just try to make sure I know where I am in the sequence of life for you. So the intent of this module, again, it's part of renal. Obviously, the kidneys have a huge, huge role as far as maintaining acid-base balance. It's a little bit broader discussion clinically, obviously, but the intent is to kind of put the kidney physiology into that picture as far as acid-base. So again, I always approach this lecture apprehensively because sometimes it seems like in here it seems straightforward, but then when you start going through, it's not always that straightforward. But we'll see where the cards land today. So your ABGs and just assessment, clinically that's a big thing if you think about it. You're monitoring CO2, O2, pH values, and really what they just represent is your body's physiology functioning the way it should be. Is the metabolism appropriate? Is it excessive in one direction energy-wise and cranking out too much of something pharmaceutically or pathologically? Is something going on to alter your physiology that's going to send this nice delicate balance of a pH and your CO2 levels at an appropriate value, and same thing with O2, et cetera, at a decent value. So the next question is, if those numbers start coming off, is trying to figure out where the teeter-totter went in this equilibrium and as to the hows and whys. So I plunked on the first couple of slides, I just put up a couple of typical algorithms or schematics you'll find out there. Every time there's a discussion with acid base, usually you find you a nice summary review article. I attached a couple on Blackboard that will give you kind of a simplistic pathway of following or getting to a determination of why this person is experiencing the disequilibrium they are. So whether they're in acidosis, alkalosis, and what's the cause of it. That's what a lot of these pathways will represent. So hopefully by the end of this, we will be able to, you should retrospectively be able to go back and kind of make sense in a pretty easy way about the reasoning for each step. Same thing here. And I guess I should say out of the gates, I highlighted them. The caveat with all this is with the acid-base imbalance, you can have ultimately two things goof that up. One is just your respiratory function. Two is your metabolism. And so often a very simplistic approach or beginning approach is figure out where's the primary cause of that getting goofed up. Is it a pulmonary issue, a ventilation problem, or is there some kind of metabolism problem? That metabolism can be, again, pathology, or it could be pharmaceutically or toxins or whatever the case is. But the bottom line is there are certain patterns you'll see that will kind of indicate, hey, that's a primary respiratory acidosis or alkalosis and so on and so forth. But then compensation goes on, those numbers change a little bit. And then also what really mucks up the waters, and again, as usually I bring it to the threshold but don't really get in too far, is the whole discussion of, yeah, you can have a respiratory acidosis. You can have somebody with a chronic scenario, a COPD patient, who then develops a metabolic acidosis or alkalosis on top of it, and then next thing you know, you got mixed disorders going on, and you have to make sense of the numbers to identify that. So that's kind of the little introduction or discussion where you're going clinically, and as usual I stand here, I'm not putting this forth intent as far as values, and I'll explain what I mean, nor the clinical reasoning, but more just the physiological basis of that clinical reasoning when you get there in your Clin Med course. So section 1, acid-base balance. Little discussion overall. Acid formation. Acid, by definitions, always wants to give up its hydrogen readily, if you will. And there's, quote unquote, two types of acids in the body, theoretically, respiratory acids and metabolic acids. And respiratory acids are really referring to your CO2 values, and we'll get to that in a moment. But the way the pathways work, that CO2, it's not really a true acid, but it eventually gets converted to carbonic acid, which is an acid. And metabolic acids, so anything from normal energy metabolism, lactic acids, those kinds of things, again, to pharmaceutical things in there. So that's kind of a little brief introduction. The key as far as measuring pH and maintaining that is obviously you're always cranking out acids, and you're always buffering them and excreting them. You're buffering them in your bloodstream. You're buffering them via your ventilation rate, and you're also buffering them via your kidney function. So if everybody's operating appropriately and the production is within normal physiological exertion or reasons, you should have the mechanisms to keep that pH in that nice little 3.5 to 4.5 level, if you will. So looking at that, as I said, the two classifications, I had mentioned this early, but in simplistic terms, CO2 is often referred to as a respiratory acid, but as I said before, it really gets converted to carbonic acid, and that whole carbonic anhydrase, CO2 plus H2O, forms that carbonic acid, which is then ready to dump off hydrogen. And we'll see this formula pop up numerous times, obviously. But the caveat with that is things you're going to look at with your acid-base balance, and one of them is the CO2 values. And so if you're in an acidic situation, the pH-D is acidic, and you see elevated CO2, then you're thinking this might be a respiratory acidosis, or vice versa. If you're in an alkaline state and the CO2 is dropped, then you start looking at a respiratory alkalosis. So the other part of all this, as I said, the metabolic acids, really these can be a result of normal metabolism. If you think about it, exercise is kind of a normal metabolic acidosis, but you compensate for it. You start cranking out a little more lactic acid. Some of that gets cycled through some different pathways. But in essence, what do? Your ventilation starts to crank up and compensate, and you're keeping things within a normal functional range. That's until you get to the point of the big bear climbs on your back, and then you're stopping whatever you're doing. But that's a little discussion as far as acids, as far as how you're producing them. So that's the whole key. But the flip side, I should back up, is how to buffer them. And as I said, you can buffer them by ventilation, in other words, taking CO2 and blowing it off, or you can buffer them with your bicarbonate as far as base and producing that. And that's what we'll start discussing over the next few slides, I think. So to do this, the immediate buffering, as I said, examples, remember way back when we did our pulmonary module and different ways to transport CO2, and it gets, the red blood cell can take that CO2 and eventually it can convert that into carbonic acid and eventually create a hydrogen and produce a base. The bottom line is you have buffers in your bloodstream and all throughout your body that are doing this all the time in adaptation to too many hydrogens floating around. So you can have a very first line immediate cell moment, if you will, to buffer things right out of the gates. If that isn't adequate, though, your next, in terms of sequencing, obviously ventilation can be a moment-to-moment. So within minutes, you can start to alter your ventilation rate to try to, if you've got too much acid production in your body, you're going to then accumulate CO2. So your body says, well, we can help with this and increase ventilation rate and try to push that CO2 out. And obviously that can be within a relatively short amount of time. And then last but not least, our kidney function, that nephron we chatted about, proximal convoluted tubule, and then the distal end. Those two were involved in hydrogen secretion or bicarbonate absorption that we had talked about. The catch with this, the kidneys, normal function, normal buffering mechanisms in the urine itself, those are relatively immediate, but that whole idea of cranking out increased production, reabsorption, that takes a little time. And kidneys ultimately are going to take about 4 days to max out their ability, if you will, to compensate. So this kind of gives you the hierarchy of just normal mechanisms. If there's too many acids, what is your body doing? At cell level, it tries to buffer. Ventilation starts to ratchet up if needed, and if it persists with time, the kidneys will adapt and start changing how much bicarbonate they absorb and how much hydrogen they secrete. Way down here, I've got fourth with a little question mark. And the only reason I put it there is calcium also has a buffering role, too. And so what you may see, and it's probably the least of their problems, somebody in a long-standing chronic metabolic acidosis, they've got issues, health issues, et cetera. But often osteoporosis may be associated with these, and you'll see this sometimes in your clin med, side effects or comorbidities or secondary effects. And that's where that connection comes from. It's some discussion of chronic long-term acidosis is going to be pulling out calcium carbonate in a kind of buffering role too. So that's not as strongly discussed. It's a much more long-term, side effect maybe is a better word, and not really a quote-unquote compensating mechanism. So I just put it out there to kind of connect the dots if you see it in a discussion clinically. So as I said, I guess I kind of was talking through, didn't realize I have a slide for each, but just kind of pulling things back. As I said, it looks like the slides kind of highlight this. And I will emphasize a little bit about types of acidosis too as well. So as I referred to in the beginning of this first line, at that cell level, within the red blood cell, intracellularly is that whole mechanism, as I said. CO2 drops in the red blood cell, eventually combines with water, carbonic anhydrase present, it will form carbonic acid. That again will further break down into hydrogen and a bicarbonate. The hydrogen stays hidden or buffered with that hemoglobin, so there's your buffering mechanism. In the meantime, it pushed out the bicarbonate out into the plasma as well, so it's kind of got a double helpful role there. So that's how the individual within the cell immediate moment can handle things. But it's really, and it makes sense, related towards a situation where you have too much CO2 or respiratory acidosis. So this intracellular mechanism is probably the primary player here, at least on the front end, as far as respiratory acids and maintaining them, versus extracellular. So the other mechanisms as far as reabsorbing or producing bicarbonate and getting rid of the hydrogens out in the ECF is more classic for your metabolic acidosis, where you've had a buildup of a fixed acid or a huge loss of base. So that's a little discussion in that regards. Not so sure I need to, I don't know what slide-wise here, this is what I mean. This is where I start mucking into the weeds here, and I always feel like there's a simpler way to put all this. I don't think there's too much more to discuss here other than the emphasis is, again, your lungs is kind of the final buffering point of this mechanism. In other words, this is where your ECF is sitting. And it can be, if carbonic anhydrase is around, it can push the conversion into H2O, CO2, and it's a way to get it out of your body in a somewhat immediate moment to help buffer this balance. But we'll talk a little more specific under each condition, respiratory, metabolic, acidosis, and alkalosis. So a couple of thoughts, though, as far as this ventilation rate or pulmonary respiration in some terms. And I guess I'll put it down. Acidosis seems to be the more, I don't know if it's more common, but gets more media attention. So I'll sneak down here first. In a situation, whether it's diseased or pathology, whatever the case is, if there's a reason you can't ventilate appropriately, you will, quote unquote, create a respiratory acidosis. That makes sense. If something's dysfunctional about your ventilation, can't get rid of the CO2, you got to build up a CO2 in your bloodstream, and you've developed respiratory acidosis. The other caveat is if there's some form of respiratory alkalosis, the reverse, if you can just turn the notch down, quote unquote, you're correcting for it. The body's just kind of figuring out a way to adapt. But more typical is the role as far as compensation with the metabolic scenario. So in a situation where I've got a metabolic alkalosis, I don't have enough CO2 in my body, I want to slow down that, so my ventilation is going to, my ventilation rate's going to be dropped down at a, its basal rate, if you will. So the body's trying to, keep as much CO2 in the body in response to a metabolic alkalosis scenario. So that's how the, lungs would compensate for that. And then it's just the opposite. You can kind of handhold yourself through these just to look at hyperventilation. In essence, you're going to blow off too much CO2, so you're going to have a situation where your pH is actually going to go down, or and your CO2 is down. And the compensation piece, if you've got a metabolic acidosis where you've ingested too much of a fixed acid, a drug, a toxin, your kidneys, loss of a base, whatever the metabolic reason, the lungs will, constantly be trying to catch up or help the cause by increasing ventilation rate to blow off CO2. So that's kind of a little discussion as far as ventilation. Kidneys-wise, two scenarios or a few scenarios with all this. One is just how the urine itself is being buffered. The acidity and the alkaline status of that urine kind of is a real immediate moment to helping secrete or not secrete hydrogen. And then two, the rate of that secretion is connected to to bicarbonate reabsorption. There's that whole exchange in the distal convoluted tubule we had briefly talked about. We'll unfortunately come revisit. Or up in the proximal convoluted tubule is just strictly reabsorption. Remember we said it has that recycling mechanism where you aren't necessarily adding a hydrogen, but you're just got a mechanism to pull the bicarbonate in the PCT. So we'll revisit those a little bit in a moment. So again, I think I've kind of wandered through each of these as far as discussion, but again, anything acidic, the name of the game is to get more base in there to buffer and to get rid of as much hydrogen as possible. And that's the ultimate kidney function, in a gross sense, and the opposite for alkalosis or alkaline situation. So let's look at how it does it. I kind of alluded to it. We'll kind of go revisit those little cell pictures on the PCT wall and the DCT itself. So the PCT, when you look at it, number one, reabsorption of bicarbonate. I'm going to kind of go out of order, I think, here. Is the reabsorption of bicarbonate is what we already talked about. We had talked about how that mechanism occurs in the PCT. Carbonic anhydrase is the catalyst for that to occur. Your carbonic anhydrase inhibitors, your diuretics, inhibit that mechanism. But that mechanism, I don't know if I put a picture up, I did. That mechanism simply allows the reabsorption of the bicarbonate, but because it can recycle or go around and around with the hydrogens, it's not necessarily producing or secreting hydrogen all that much. So the net effect is, bottom line, PCT is trying to pull back all that bicarbonate that got filtered in the first place. It's just trying to get it back in the bloodstream. So it's a pretty straightforward mechanism to do that. So the ultimate function, again, is to increase the base. It's not a huge role as far as secretion of hydrogen ions. The end in the nephron, that's its job, is to secrete these things like crazy and also pull in more base as well. So the other piece of this, it says production of ammonia. We talked briefly about this in our nephron tour, and we'll sort of talk briefly about this, but ammonia and phosphate are the two buffering mechanisms within the nephron itself, within the fluid, to buffer the acidity of the urine itself. So basically, these are the carrier mechanisms to take those secreted hydrogen ions out of the blood or out of the nephron wall and put them into the urine and be able to excrete it out, if you will. So they're the buffering mechanisms for that, or the carriers to do that. Each one has a little different role as far as superacidic or normal values, but both of them are doing that. But back to this PCT, the bottom line is the production of this ammonia is, functionally occurs in the PCT. So the moral of the story is damage in the PCT can also alter that, and the distal convoluted tubule from doing its job in acid-base balance as well. So that was a long way about that. We'll get back to it. I probably should just, again, when we talk about the DCT buffering. That might make a little more sense. So things that are going to ratchet up bicarbonate reabsorption. And so when that kidney, we talk about renal compensation, and it takes 3 or 4 days to max out. It takes about 4 days to get all of these changes to really be going as much as cellularly possible, if you will. But if you think about it, all of these should make sense if you kind of wander through them one at a time. GFR, if I'm cranking up GFR, it's the same as the sodium. There's too much sodium going through, and really an increased GFR just means you're pushing more stuff into the nephron. So if I push more in, the nephron should be pulling more out. So, in essence, that's how GFR can determine a little bit about bicarbonate reabsorption. PCO2, obviously, that's the whole mechanism of a respiratory acidosis. And if that's occurring, eventually it's telling the kidneys to respond by turning up that mechanism to reabsorb bicarb. Extracellular ECF expansion, if you think about it, basically what's going on is I've got too much fluid, and the body's looking at this as if there's not enough hydrogen in there, and really not enough sodium either as well. So essentially what it's going to want to do is be pushing out the HCO3 in an attempt to maintain or keep hydrogen in the body. They're always going in opposite directions. So if the body's interpreting this as not enough hydrogens around, then they certainly aren't going to do things to keep bicarbonate in there. They're going to do things to get rid of the bicarbonate. And then angio2, again, that whole issue as far as the whole idea of sodium and reabsorption and bicarbonate reabsorption go hand in hand. So if angio2 is telling that kidney pull back sodium and ADH is in there pulling back water, just because they go hand in hand, you're going to have that increased bicarb being pulled back in as well. So the bottom line is, obviously, they're all interrelated. Obviously, some can be going this way, some going that way, but it's the net sum that says, is this kidney compensating or not for whatever the body's circumstances. All right, so that's PCT. That's the front end of this nephron. If we take a look at this thing at the end of the nephron, as I said, this is where all the action's going on, really with excreting and getting rid of these hydrogens. So when your body's, you're in an acidic state, you want to get rid of these hydrogens, there's two mechanisms to do it. You can go through converting it to carbonic acid and pushing it out as CO2, or you can take it down to the kidney and push it out the distal end of that nephron. Those are kind of your two directions to go to compensate and equalize it. And so in that DCT, we talked just like with the other things, a majority of things get reabsorbed, in the front end, but at the very end, this distal convoluted tubule and / collecting duct, it's always fine-tuning reabsorption, the sodium issue, and same thing with the bicarbonate. So reabsorption is continuing. And again, it's going hand in hand. Whenever the mechanism is pulling back bicarbonate, it's pushing a hydrogen out of that nephron into the urine to excrete it. When it gets in that fluid, it needs to have a gradient and a carrier, and that's what the phosphate and the ammonia do at this point in that collecting duct. So that's the role I was kind of taking a big circle around trying to describe earlier. So looking at reabsorption, we already had chatted about this, but essentially the whole mechanism, there was the intercalated cells. We said the two different types of cells, principal in these guys. And so the whole exchange as far as bicarbonate being pulled in and the hydrogen being pushed out is occurring at that level. So if I look at this cell, here's the intercalated cell. In essence, I can have water, CO2 absorbed into it, and I can convert that to that carbonic acid that eventually can get disassociated into a bicarbonate, into a hydrogen. So remember we talked about that co-transport or exchange mechanism of sodium and hydrogen down at this level. So if the body is pulling back sodium, or if there's enough sodium present to be doing so, it's going to help feed this cause too as well. But as I have this exchange going on, I'm pushing out my hydrogens, and I'm taking a bicarbonate and pushing it back into the bloodstream. So it's a kind of a one-to-one ratio, if you will. So if you need to be excreting hydrogen, something to crank this mechanism up for excretion and getting rid of it, at the same time, you're also throwing more base into the bloodstream if the kidney's healthy to help the cause in neutralizing things. So that's kind of an overview as far as the pathway. The main difference here is you're not recycling a hydrogen the way you do in the PCT. You're literally excreting one and pulling back and creating base for reabsorption. Meanwhile, once these hydrogens get dumped in the lumen, into that urine, if you will, there's a couple of ways to buffer them. Not going to chase it too much on the little nuances of our biochemistry here. Of kind of putting them up there as pulling up some cobwebs of remembering some of these pathways. But really, what I'd like to appreciate is you have a phosphate mechanism and also the ammonia mechanism. And the caveat is this phosphate mechanism, if the gradient, if there's enough of this phosphate in the urine or in the lumen, that's going to be able to create that gradient for helping excrete this hydrogen out of the body. So that needs to be present, and the formation occurs throughout the kidney, other places. But the formation or its function only is really effective in kind of neutral situations. In other words, when everything's good and A-okay, if you will, the kidney's functioning okay, you don't have any big extremes going on, and that urine production going on in the nephron is within fairly reasonable pH values. It's going to be the primary buffering or carrier to get rid of these hydrogens. So that's kind of the take-home message here as far as this comment. Meanwhile, if I sneak down to the ammonia mechanism, and so again, we talked about the PCT play a role in producing this. So again, you can see how if there's damage to the PCT, you have multiple ways of affecting acid base, and this is just one of a complex pathway. But the bottom line is this ammonia buffering system is far more effective in the extremes. So in other words, if something's going on and now this urine or this fluid going through this nephron as an extremely acidic scenario, this ammonia mechanism needs to be in place to help get the excretion to occur and to buffer that fluid out. So that's kind of the nutshell of the DCT. So at the end of the nephron, you are reabsorbing, but you're also excreting or secreting hydrogen. In the PCT, you're just reabsorbing base. You aren't necessarily excreting or secreting a lot of hydrogen. Meanwhile, in that distal convoluted tubule at the end of the nephron, you need the appropriate buffers to finish off the story of getting it out of that urine and out of the fluid. So that's kind of a overview as far as mechanisms to occur. Did plunk up a few things as far as what's going to, promote or inhibit acid secretion or hydrogen secretion in that distal nephron. And again, a lot of it should make sense. I'm going to skip through this one and sneak downstairs here. obviously a respiratory acidosis, no rocket science there. You've created an acidic environment, and the kidneys can compensate for it. Meanwhile, aldosterone, remember we talked about the connection as far as pulling back a sodium. And so if you're encouraging that gradient, you're also encouraging this mechanism we just talked about throwing out a hydrogen into the lumen or secreting a hydrogen into the lumen. So aldosterone too is, any of that has got a pro-hydrogen secretion function, if you will. Meanwhile, up here, hypokalemia. This is a little dangerous to just look at the gradient. In other words, if you look at what's going on where aldosterone is going to be pulling back a sodium and pushing out a potassium in that distal nephron, this doesn't totally make sense. You're like, that doesn't add up. Why would that promote more of it? Really what this is, it's affecting multiple levels. In other words, it's affecting throughout the body, intracellular. In other words, there's intracellular fluids. If you don't have enough potassium, you're going to change the balance of your hydrogens. They're going to want to go into the cell, and the potassium's going to want to come out of the cell, things like that. So the bottom line is all of the balances potassium-wise, the net total of them, eventually may have an effect on promoting hydrogen secretion. But the other role here too is just to kind of connect the dots a little bit with that PCT and DCT that I had talked about. In the PCT, where that production of pneumonia is, as we said, you need that to be able to finish off excreting and buffering hydrogen out of the kidney. So decreased potassium levels have a production effect on that. But again, it's not a single, don't be tempted to just look at the little schematic where you see, sodium going in, potassium going out, and that it's too simplistic to look at it that way as far as that balance goes. So anyways, again, just gives you a little discussion kind of section by section along the way as far as this kidney function. Meanwhile, as I said earlier, just the fourth mechanism, just briefly, we had talked about if your bone is exposed, that balance as far as calcium and demineralization, if it's exposed long-term to metabolic acidosis, there is an increased amount of calcium released, and that does play a buffering role. So again, that's more to connect the dots again as far as clinical symptoms associated with a long-term acidosis scenario. But just kind of want to plant the seed as where the connection might come from. All right. As I'm killing you softly with the song here, why don't we take we'll pause you and we'll regroup, get excited a little bit about looking at these more clinically. Might help the cause as far as values. But clear your heads.